Welcome to Diabetic Training Module. Today we are going to talk about diabetic ketoacidosis, hypoglycemia, and diabetes in Ramadan. Diabetic ketoacidosis. Diabetic ketoacidosis is an acute, major life-threatening complication of diabetes. DKA is characterized by hyperglycemia, ketoacidosis, and ketonuria. DKA occurs mainly in patients with type 1 diabetes, but it is not uncommon in some patients with type 2 diabetes. All three criteria must be present for diagnosis of diabetic ketoacidosis. 1. Capillary plasma glucose more than 11 millimol per liter. 2. Capillary ketones more than 3 millimol per liter or urine ketones more or same as 2+. 3. pH less than 7.3 and or bicarbonate less than 15 millimol per liter. Management of diabetic ketoacidosis aims of treatment is to achieve rate of fall of ketones at 0.5 millimol per liter per hour or rise of bicarbonates 3 millimol per liter per hour and fall in plasma glucose at least 3 per hour and maintain serum potassium within normal range. Avoid overcorrection of hyperglycemia. Lowering blood glucose less than 14 millimol per liter within first 12 to 24 hour. Hydration, correction of dehydration is a priority. Rate of hydration should be guided by hemodynamic status, hydration, serum electrolytes, and urinary output. For correction of dehydration with systolic blood pressure less than 90 millimeters mercury, give 500 milliliters of normal saline over 10 to 15 minutes and follow by 1 liter of 0.9% saline for next hour. For correction of dehydration with systolic blood pressure more than 90 millimeters mercury for first hour, start the IV drip 1 liter of 0.9% saline. Continue the fluid replacement via infusion pump depending on hydration status. As for potassium replacement, aim to maintain serum potassium between 4 to 5 millimol per liter. Withhold if there is no urine output. Plasma glucose monitoring, hourly capillary glucose monitoring until the glucose reaches 8 to 12 millimol per liter, then followed by 2 to 4 hourly monitoring. As for transitioning from 4 insulin to subcutaneous basal insulin, patient should be eating and drinking. Overlap subcutaneous insulin with infusion for half an hour for insulin analogs and 1 hour for human insulin. To calculate basal bolus regime, estimate total daily dose by multiply patient's weight in kilogram by 0.5 unit to 0.75 unit. Monitoring and resolution. Monitor patient hourly for vital signs and input-output charting. 6 hourly BUs and blood or urine ketones. Resolution is defined as pH more than 7.3 and plasma ketone less than 0.6 millimol per liter. Hypoglycemia. Hypoglycemia is defined by either one of the following 3 conditions. 1. Low plasma glucose level, less than 3.9 mol per liter. 2. Presence of autonomic or neuroglycopenic symptoms. 3. Reversed by carbohydrate intake. Symptoms of hypoglycemia. Symptoms of hypoglycemia is divided into autonomic and neuroglycopenic. Autonomic symptoms include trembling, palpitations, sweating, anxiety, hunger, nausea, and tingling sensation. Neuroglycopenic symptoms include difficulty concentrating, confusion, weakness or stroke-like symptoms, drowsiness, vision changes, difficulty speaking, headache, seizures or coma. Risk factors for hypoglycemia include advancing age, severe cognitive impairment, poor health knowledge, uncontrolled T2DM with glucose variability, hypoglycemia unawareness, long duration of insulin therapy, renal and hepatic impairment, peripheral and autonomic neuropathy. Treatment of hypoglycemia. The aims of treatment are to detect and treat a low plasma glucose level promptly, eliminate the risk of injury to oneself and to relieve symptoms quickly. Avoid overcorrection of hypoglycemia, especially in repeated cases, as this will lead to poor glycemic control and weight gain. Acute management of hypoglycemia. If the patient is conscious, give him 15 grams of simple carbohydrate. Monitor glucose every 15 minutes until the glucose level more than 3.9 millimol per liter. He can continue to eat his usual meal on time, and is important to find out the cause of hypoglycemia to avoid further episode. If patient is unconscious, immediately give IV drip D50 of 25 to 50 milliliters and admit the patient to hospital. Examples of 15 grams of simple carbohydrate. 15 grams of glucose in the form of glucose tablets. 15 milliliters, 3 teaspoons, or 3 packets of sugar dissolved in water. 175 milliliters, 3/4 cup, of juice or regular soft drink. 6 hard candy, 1 equal to 2.5 g of carbohydrate. 15 milliliters, 1 tablespoon, of honey. Once hypoglycemia has been reversed, the patient should have the usual meal or snack that is due at that time of the day to prevent recurrent hypoglycemia. Evaluate cause of the hypoglycemia and educate patient on how to prevent future episodes. Diabetes treatment, OHA and insulin, regime may need to be reviewed and adjusted. Diabetes management in Ramadan. Ramadan fasting is observed by Muslims worldwide as fasting from dawn until dusk daily for 29 to 30 days. Fasting in certain individuals with diabetes may be associated with adverse outcomes, hence they are not obliged to fast. However, many diabetic patients choose to fast, as shown in the Epidemiology of Diabetes and Ramadan from IDF-DAR study. The adverse outcomes during fasting include dehydration, hypoglycemia, and hyperglycemia/ketoacidosis. Risk categories for patients with type 2 diabetes. Patient is considered very high risk if he has one or more of the following. 1. Severe hypoglycemia within the 3 months prior to Ramadan. 2. DKA within the 3 months prior to Ramadan. 3. Hyperosmolar hyperglycemic coma within the 3 months prior to Ramadan. 4. History of recurrent hypoglycemia. 5. History of hypoglycemia unawareness. 6. Acute illness. 7. Pregnancy and pre-existing diabetes, or GDM treated with insulin or sulfonylureas. 8. Chronic dialysis or DKD stage 4 and 5. 9. Advanced macrovascular complications. 10. Old age with ill health. Patient is considered high risk if he has one or more of the following. 1. Type 2 DM with sustained poor glycemic control. 2. Well-controlled type 2 DM on MDI or mixed insulin. 3. Pregnant type 2 DM or GDM controlled by diet only or metformin. 4. Chronic kidney disease stage 3. 5. Stable macrovascular complications. 6. Patients with comorbid conditions that present additional risk factors. 7. People with diabetes performing intense physical labor. 8. Treatment with drugs that may affect cognitive function. Patient is considered as moderate or low risk if he has well-controlled type 2 DM treated with one or more of the following. 1. Lifestyle therapy. 2. Oral hypoglycemic agent. 3. Basal insulin. It is important to categorize patients who intend to fast based on risk stratification as listed. Those in high and very high risk categories should abstain from fasting. Preparation prior Ramadan. A pre-Ramadan medical assessment should be performed to categorize patients in terms of risks of fasting as well as to optimize their management. These include general well-being, diabetes medications, glycemic control, comorbidities, and complications. Patients and caregivers should receive education concerning self-care regarding the following. Risks of adverse effect of fasting. How to do SMBG. Indications for termination of fasting. Meal food choices and fluid intake. Exercise and physical activity. And modifications of glucose-lowering medication. There are several potential risks associated with prolonged fasting such as hypoglycemia, severe hyperglycemia, dehydration, acute kidney injury in patients prone to dehydration, particularly elderly patients and those with impaired kidney function. It is therefore important to increase patient awareness and to reduce risks while, if possible, enabling patients to participate in their spiritual experience of fasting during Ramadan. During Ramadan, patients are advised to monitor their plasma glucose and, most importantly, when symptomatic of hypoglycemia. The frequency of SMBG depends on risk factors and current medications. For those at moderate or low risk, this may be once or twice a day. Those at high or very high risk should check their plasma glucose levels several times a day. Patients on insulin or SU may need to monitor their plasma glucose levels more frequently. The frequency of plasma glucose testing is dependent on the insulin regimen and the risk of hypo or hyperglycemia. Criteria of ending fasting is when the glucose fall below 3.9 millimol or glucose rise to 16.7 millimol or when patient is symptomatic. Meal planning, food choices, and fluid intake. Recommendations for sahur: it should never be omitted. Should consist of a balanced meal with adequate carbohydrate. To be taken as late as possible, just before dawn. Intake of salty foods should be avoided to reduce risk of dehydration. Recommendations for iftar: breaking of fast, it should not be delayed. Intake of high sugar foods should be avoided. However, 1 to 2 korm at the start of iftar may be taken as part of carbohydrate exchange. Sufficient fluid should be taken to replenish fluid loss during the day. Aim for 8 glasses of fluid a day. The main meal is encouraged after the performance of Maghrib prayers. Supper can be considered as a pre-bed snack. Exercise and physical activity. Light and moderate intensity exercise on a regular basis. Avoid rigorous exercise during the day because of the risk of hypoglycemia. The timing of exercise is preferably performed 1 to 2 hours after iftar. Performance of Tarawih prayers is a form of physical activity. Glucose-lowering therapies should be individualized during fasting. Glucose-lowering therapies of choice are those with low risk of hypoglycemia and do not require modification with regards to dose and timing of administration. The preferred glucose-lowering therapies are those which have low risk of hypoglycemia. Oral glucose-lowering therapies which have been proven to be safe in Ramadan include metformin, glimepiride, gliclazide, sitagliptin, vildagliptin. SGLT2 inhibitor has lower risk of hypoglycemia, but are associated with some safety concerns, in particular, dehydration, and should be used with caution in patients with DKD greater than or equal to stage 3. The principles of oral glucose-lowering therapies modifications are: the non-fasting morning dose should be taken during iftar, and the non-fasting evening dose should be taken during sahur. And the dose of glucose-lowering agents may be maintained or reduced depending on risk of hypoglycemia. Insulin adjustments during Ramadan. For insulin regime with basal insulin only, basal insulin to be taken at bedtime or after iftar meals. May need dose reduction if there is risk of daytime hypoglycemia. For pre-mixed insulin once daily, inject usual dose at iftar meals. For pre-mixed insulin twice daily, reverse the doses. Morning dose given at iftar and evening dose at sahur. Insulin dose at sahur reduced by 20 to 50% to prevent daytime hypoglycemia. Insulin dose at sahur reduced by 20 to 50% to prevent daytime hypoglycemia. Or changed to short or rapid acting. As for basal bolus insulin dose adjustment. For basal insulin, taken at bedtime or any time after iftar meals. May require dose reduction if there is daytime hypoglycemia. For bolus/prandial insulin, when sahur, take usual pre-Ramadan breakfast or lunch dose. May require dose reduction to avoid daytime hypoglycemia. When lunch patient need to omit. When iftar, take the usual pre-Ramadan dinner dose. May require dose increment. These are the reference used. Thank you.